Pregnancy Discovery and Abortion Access, a timeline of embodied signals and structural realities. Pregnancy is often discovered between 4 and 6 weeks gestation, typically triggered by symptoms like nausea or a missed period. Abortion access during this early window is shaped by provider availability, legal constraints, and gestational age limits, with most medication abortions offered up to 10 to 11 weeks. Let's walk through the experience of pregnancy discovery alongside the structural realities of abortion access, anchored in timelines and symptom charts. Phase 1. Discovery in the fog of symptoms, approximately 3 to 6 weeks gestation. For many, pregnancy begins not with certainty, but with a question: why do I feel off? Around week 3 to 6, subtle physical cues begin to surface: fatigue, breast tenderness, frequent urination, and most notably nausea, which prompts suspicion in 35 to 40% of cases. A missed period, occurring around week 4 to 6, is the second most common trigger, especially for those with regular cycles. Some may experience implantation bleeding, light spotting that occurs roughly 6 to 12 days after fertilization, and misinterpret it as a light or early period. Another form of indirect discovery, said to be experienced regularly by roughly 40% of menstruating people, is the presence of a sharp twinge known as Mittelschmerz, a one-sided abdominal pain that occurs around ovulation, typically mid-cycle, and signals the release of an egg. But just as notable are those who do not feel it. The absence of Mittelschmerz can spark its own kind of inquiry. Was ovulation missed? Was it silent? Did conception occur without any perceptible cue? These embodied signals, whether felt, absent, or misread, are often ambiguous, requiring emotional awareness, cycle tracking, or visual cues to interpret. Ovulation marks the possibility of conception, while implantation signals its actualization, yet both are often cloaked in subtlety. Phase 2. Confirmation, approximately 4 to 6 weeks gestation. Once suspicion arises, confirmation typically comes via a pregnancy test, urine or blood, around week 4 to 6. While tests are not usually the initial trigger, they serve as the pivot point from uncertainty to decision-making. Ultrasound confirmation, used for dating and viability, enters the picture later, around week 6 to 12, but is rarely the first step. Phase 3. Decision-making and access, approximately 4 to 9 weeks gestation. The abortion care timeline begins almost immediately after discovery. Phase typical duration, gestational range. Pregnancy discovery day 0, approximately 4 to 5 weeks. Initial decision-making day 0 to 3, approximately 4 to 5 weeks. Contacting a provider day 1 to 5, approximately 4 to 5 weeks. Consultation and screening day 3 to 10, approximately 5 to 7 weeks. Prescribing administering day 5 to 20, approximately 6 to 9 weeks. Grace period and safeguards. Travel time, transportation, discretion, planning. Day 5 to 20, approximately 6 to 9 weeks. Most medication abortions are offered up to 77 days, 11 weeks, after the last menstrual period. Narrative insight, the compressed window of agency. This timeline reveals a compressed window. From the first twinge of nausea to the final day medication abortion is available, the arc spans roughly 4 to 9 weeks gestation. Within this period, individuals must detect, confirm, decide, schedule, and receive care, often while navigating emotional, logistical, and legal complexities. The narrative of early pregnancy is not just biological, it is temporal, embodied, and deeply shaped by systems. Discovery is often accidental, access is often urgent. And between the two lies a landscape of decision-making that demands clarity, support, and time. Why the 11-week threshold? Medication abortion involves 2 drugs, mifepristone, which blocks progesterone, and misoprostol, which induces uterine contractions to expel the pregnancy. The FDA currently approves this regimen for use up to 70 days, 10 weeks after the last menstrual period, though some providers extend it to 77 days, 11 weeks, based on clinical evidence. Beyond this point, several factors shift. Increased tissue volume. As gestation progresses, the embryo and surrounding tissue grow larger, making complete expulsion more difficult. Higher risk of incomplete abortion. After 11 weeks, there's a greater chance that retained tissue may require a follow-up surgical procedure to prevent infection or bleeding. Effectiveness declines. While mifepristone and misoprostol can still induce abortion beyond 11 weeks, the success rate drops from over 95% to around 87 to 90% by 13 to 14 weeks. More intense physical symptoms, cramping, bleeding, and gastrointestinal side effects become more severe and prolonged, resembling a second trimester miscarriage. Variable effectiveness. Studies show medication abortion can still work up to 13 to 15 weeks, but higher doses or additional misoprostol may be needed. Safety and oversight. The decision to cap medication abortion at 11 weeks is not arbitrary. It reflects a balance between efficacy, safety, and patient experience. After this point, in clinic procedures like vacuum aspiration or dilation and evacuation, D&E, are preferred because they offer immediate resolution, lower risk of retained tissue, more controlled environment, especially for later gestational ages, global guidelines. The World Health Organization supports medication abortion up to 12 weeks, and some studies advocate for safe use up to 15 weeks, but these require clinical oversight, adjusted dosing, and access to emergency care if complications arise. In short, the 11-week mark is a practical boundary where medication abortion remains highly effective, manageable at home or via telehealth, and less likely to require surgical backup. Beyond that, care shifts toward more intensive clinical support. This helps explain the timeline and operation of over 85% of abortion and involvement of discovery and action. Ethical considerations, pro-life and pro-choice perspectives. This timeline of pregnancy discovery and abortion access highlights a compressed and often chaotic window where biology, emotion, and systems converge. Within this space, two deeply held worldviews offer contrasting interpretations. Pro-life perspective. From a pro-life viewpoint, the same timeline marks the beginning of human life, with each phase, ovulation, implantation, and embryonic development seen as part of a continuous moral arc. The fact that pregnancy is often discovered after implantation reinforces the belief that life begins before awareness, and that abortion even early ends a life already underway. Pro-life advocates may argue that the compressed window should not justify termination, but rather call for greater support, education, and alternatives that affirm both the life of the unborn and the needs of the pregnant person. From a pro-choice standpoint, the early gestational window represents a critical period of bodily autonomy, self-determination, and timely access to care. The ambiguity of early symptoms, the unpredictability of discovery, and the narrow window for medication abortion underscore the need for unrestricted access, legal protection, and supportive infrastructure. Importantly, the option of abortion, whether taken or not, allows someone to choose pregnancy rather than pregnancy choosing them. This distinction is foundational. It transforms parenthood from a reactive state into a conscious, aspirational commitment. In that moment of decision, a person willingly selects all that it means to be a parent rather than feeling like a passive vessel, a chess piece moved by biology, used only as a means to the end of procreation. This act of choosing affirms agency, direction, and flourishing. It is precisely this self-directed embrace that can make great parents, those who step into the role not by accident, but by intention. Advocates emphasize that decisions about pregnancy are deeply personal, and that the ability to act swiftly, especially before 11 weeks, is essential to preserving agency, health, and dignity.